We are going to review the surgical techniques of the retrosigmoid transcanalicular approach for this patient in her 60s who presented with this left-sided vestibular schwannoma and complete hearing loss. The patient is positioned supine on a 3/4 par bench with the left side up. We perform a retroauricular C-shaped incision, and then we dissect the muscle plane on a separate layer other than the skin to aid with the reconstruction. This is a vascularized flap that heals pretty well afterwards. We expose the asterion in a subperiosteal manner, and the asterion marks the junction between the sigmoid and their transverse. So that's where we start our craniectomy, which is the 2.2 retrosigmoid craniectomy, in which we maximize the exposure of the transverse and the sigmoid sinus. This is very relevant to minimize the retraction of the cerebellum and also afford sufficient subdural exposure. We incise the dura in this V-shaped fashion in a way that both sinus are traction against the bone, so the blood loss is minimal. And we incise at the junction of both sinuses to maximize the view through the retrosigmoid corridor. A small patty of telfa is used to retract the cerebellum and open the cistern along the lower coronary nerves. This way we can actually expose the lower bottom of the tumor in this case, which was very large and it was getting all the way to the jugular foramen. As you can see here, the spatula is positioned to retract the cerebellum, and we start by mapping the posterior surface of the tumor, ensuring that there are no facial nerve fibers that can be disrupted. At this point, we just coagulate and incise the tumor capsule, and we perform some debulking with our sonopet to reduce the tumor size and being able to start deflating the tumor and rotate to find the lower pole. Here we are finding the lower coronary nerves, 9th coronary nerve, and we protect it with a patty, and we continue our dissection in our attempts to try to find facial nerve. Here we find a 7 and 8 complex, and we just continue our dissection circumferentially towards the brainstem. Here I already stimulated and I ensure that there are no facial response, so this should be a vestibular nerve. And I continue my dissection, combining sharp and blunt dissection towards the brainstem in order to preserve all this pre-brainstem or veins. Here I'm just turning the microscope up to preserve the superior protrusial vein and then later the cochlear nerve. Here are making my landmarks that includes the tubingen line inferiorly and the operculum posteriorly to expose the internal acoustic canal. The internal acoustic canal is drilled with this 2 or 1.5 diamond drills, and once I'm able to expose 270s or 180 degrees, I'm able to continue my dissection towards the mid-size and further dissect the tumor of the brainstem. Here I'm just trying to find the proximal end of the facial nerve. Here I find some fiber corresponding to vestibular nerve that are not stimulated, and deeper into that I find the facial nerve that is a squish and already in close relation with the eye count. I protect the facial nerve. I ensure that this is just a vestibular branch that doesn't need to be preserved, and I continue my dissection below the tumor. The tumor is too bulky, so we need to reduce its volume by doing further debulking with the sonopet. It's important to keep traction or contraction with a cottonoid to avoid that dissection actually injure the facial nerve. Here I'm stimulating the facial nerve at 1 milliamp, 0.1 milliamp, and we are obtaining a response. Here I'm just stimulating this branch that is not eliciting any response correspond to the cochlear nerve. So I continue my dissection down between the cochlear and the facial nerve. On the bottom we see the surface of the brainstem, and I continue with further debulking, ensuring that the integrity of both the facial and the cochlear nerve is preserved. I continue to monitor the 7, and I continue the dissection. You see how this is a squeeze. This is a configuration that is type 3 as per Youssef classification, as the tumor is displaced up and severely squeezed by the tumor. See how the tumor capsule infiltrates the whole tumors that opens as a fan in the direction of the internal acoustic canal. So sharp dissection here is critical to afford or minimize any facial weakness. So we continue our dissection using the sharp tweezer, and then we continue with sharp dissection, leaving a small thin layer of the tumor capsule. At this point, we'll see that the facial nerve still stimulated at 0.1 milliamp as is the beginning, and we continue our dissection, combining our dissection with the use of the stimulator, the monopolar stimulation. Continues our dissection, trying to preserve any fibers of the vestibular nerve that will maximize the chances of preserving facial integrity. Here I'm cutting the last few branches of the vestibular nerve, and I continue my dissection, trying to keep the perineuron intact to the best of my abilities. We'll caution here with very finicky and sharp dissection, and we're able to preserve the nerve with a small stump of the cochlear nerve that was sacrificed as the patient had complete hearing loss and the tumor was fairly large to consider any potential recovery. Facial nerve was still stimming at 0.1 milliamp after the case. We just reconstruct with bovine pericardium graft and a watertight fascia, close it with bone cement. The patient grade has a temporary facial palsy, House Brackman 2, that completely recovered at 3 months follow-up. Thank you very much. I hope you enjoy this series and follow for more. Thank you.